The Australian Primary Healthcare Nurses Association acknowledges that we are meeting on the traditional country of the Kaurna people of the Adelaide Plains and pay respect to the elders past and present. I recognise and respect their cultural heritage, beliefs and relationships with the land. I acknowledge that they are of continuing importance to the Kaurna people living today. Welcome, my name's Helen Storer. I'm on the APNA board and I'm the facilitator for this afternoon's session, which is National Breastfeeding Strategy and Women's Health. And I have with me Miranda, who is a clinical nurse. Are you a clinical nurse or a clinical... They've just given me a handwritten... I
have been a CNC lactation.
Yeah, CNC lactation at the Royal Women's Hospital in Melbourne, and we're very pleased to have her here. I think everyone knows where the emergency exits are, the toilets are, and if you can just make sure your phones are turned off, and I'll give Miranda the floor.
Hello, that works, doesn't it? Yep. Awesome, because I wander around, sorry. Thank you so much for coming. I'm so thrilled to have people. I saw the concurrent sessions and was like, nobody's coming to my session. Well, I'm so happy you're here. So my name's Miranda, and I have two jobs. Point 5, I work as Manager of Breastfeeding Information and Research at the Australian Breastfeeding Association. And point 5, I'm a lecturer at La Trobe University, and I teach the undergraduate nurses, who end up knowing an awful lot about breastfeeding. So my background is that I'm a neonatal nurse. I'm a neonatal intensive care nurse and paediatric intensive care nurse. A direct entry paediatric nurse from the UK. We have these weird things where you can just be a paediatric nurse. I was never an adult nurse. And I then went from PICU into education. And then I had a baby and got really confused because it was really hard breastfeeding that baby. And I didn't understand why, because I'd been helping women to breastfeed their babies in the neonatal unit for 15 years. Why was it difficult? And the shock of, this should not be this hard, and there should not be things that are a surprise to me, made me realize that we have a lot of work to do in infant feeding. And so I trained to be a lactation consultant, and then I decided that I wanted to do more academic research in breastfeeding, and I now have a PhD in early breastfeeding difficulties. And after finishing that, I could have niched myself into this teeny little academic niche of breastfeeding difficulties. But I've been very lucky that the university's employed me to teach general nurses, but also I got this amazing role at the Australian Breastfeeding Association, because the person who'd been doing it for the last 10 years decided to retire and hand over to me. And I am thrilled to be able to put my expertise to good use, because I didn't ever think I was going to be able to do that. Now today I've got an hour and a half to talk about breastfeeding. I'm a bit of a last minute shoe-in because I had a cancellation. So I have had to cobble together a series of different presentations to cover the learning outcomes that the conference wanted me to talk about. So I've got 4 different presentations, 2 of which are from colleagues of mine, because I wanted you to hear about some of the things they've got going on as well. It's a lot to get through. We'll see how we go. But it's also very flexible, and if you've got stuff that I'm whizzing past, you're like, hang on a minute, I need to know more about that, just stick your hand up and I'm really happy to interrupt things and see how we go. So I'm going to talk a little bit just about breastfeeding and peer support, because the Australian Breastfeeding Association is who I work for, and we have some excellent work that's going on in our organisation, but we also have a long way to go in Australia. So our best evidence for how to protect and promote breastfeeding is through the 10 steps, the BFHI. Now, some parts of Australia have really good coverage of baby-friendly. Tasmania, for example, all the hospitals in Tasmania are baby-friendly. In Victoria, only a couple. I don't know what it's like in South Australia. Does anyone know? Are you baby-friendly? Baby-friendly have the 10 steps to promoting and protecting breastfeeding. And amongst them are things like making sure that professionals are educated, making sure that women aren't exposed to formula marketing. And then step 10 is that community support is essential to sustaining breastfeeding. And community support is something that culturally in Australia we lost. So way back in the 1970s, probably only 20 to 30% of people even began breastfeeding. We lost our breastfeeding culture. And then birth, when it came into the hospitals from the community, became medicalised, and breastfeeding became medicalised at the same time as birth did. And all the problems that we see with breastfeeding at the moment, and there are considerable problems with breastfeeding, all of them stem from that medicalisation of pregnancy and birth. What we do to pregnancy and birth impacts on women's ability, capacity to breastfeed. And because we lost breastfeeding in the community, I was born in 73, I'm exclusively formula fed. That was fairly normal in the 70s. We have a whole generation of women who never breastfed, who now with their children having babies aren't particularly able to support them because they just don't know how to do it. It's not something, their norms of infant feeding and infant behaviour are formula feeding infant norms and infant behaviour. Even the way that we think about what breastfeeding looks like is actually bottle feeding positions. A lot of it is all, really unfortunately, has been medicalised and skewed. So peer support is something that we've had to rebuild from the ground up, and the Australian Breastfeeding Association started way back, more than 50 years ago, and has built up over time. And we now have a 24-hour, 7-day-a-week helpline, which was funded by the government 10 years ago, and has been running for 10 years. Our funding is just about to run out, and we're reapplying for our funding at the moment. And we have peer counsellors who do an extensive and really rich training in counselling as a practice, and then breastfeeding expertise as complementary to that practice. So a lot of their work is about counselling skills and talking and listening to people, and then the kind of breastfeeding is run side by side of that. We also have social media, and we have a lot of engagement through social media with supporting our education. So 24 hours a day, 365 days a year, 700 volunteers, 6,500 calls each month. We answer the vast majority of them. We've been funded by the Australian government for 10 years, 800,000 calls in that time. The Cert 4 that our breastfeeding counsellors have to complete is fairly onerous. It's a lot of work. It's very in-depth. We are a registered training organisation at the ABA. And 28,000 hours to the service each month. That's women supporting women for free. There is nothing else like that. There's no men out there supporting men for free in that kind of way. I think that it's amazing. It's a feminist thing. I mean, in some ways, it is a shocking thing that we have to work for free for each other to support a normal bodily function, and that this is needed. But it's amazing. I love these women, the fact that they do this, and they've been doing it for so long. We survey the people who call the helpline, and we find that generally speaking, people find it extremely helpful. They get what they expect from us. I think sometimes when you hear people talk about the ABA, sometimes the most vocal people are the people who've had a problem and didn't get what they wanted, but actually when we actually survey the people who call, we find that mostly it's a very successful model of supporting women to breastfeed. When people are looking for where else would they get their support from if they hadn't called the ABA, you'll find that GPs, early childhood nurses, that's where people are going, where they would go. So they go to primary health care, to their ad hoc, their GP, their immunisation nurse. That's where they'd be expecting. Women expect the people that they encounter in primary health care to know about breastfeeding and to be able to support them. However, we know... Hello?
Oh, sorry, can I just ask a question that I just found it interesting that one of the wife on there has one of her replies? go-to for info?
I know, it's interesting, isn't it? Yeah. I think Australian midwifery is very good at, it is day 4, it is day 5, it is day 6, you're discharged.
There's not many community funded midwifery.
A lot of the women, once they get out of hospital after their babies, I've spoken to them and I've said, can't you go back to the hospital with this question with your, oh no, they didn't want to know me up, you know, and that's the scary part too.
I mean, and they're being discharged.
That's not, because when I worked as a midwife, in a private hospital, the women were still allowed to ring up with questions, but in the public system that doesn't.
Well, and they're being discharged 24 hours, less than 24 hours, so their milk hasn't even come in, and they're being discharged.
And they're being picked up by the maternal and child health nurses quite early on. I mean, other places in Europe, they will have, at least 10 days. They might have 6 weeks. In New Zealand, they get covered for 6 weeks.
In New South Wales, they have, I don't know whether it's in all hospitals, but a lot of the hospitals have a 2-week community midwife program after they're discharged, and they have access to that, not in face-to-face visits every day, but for 2 weeks after they're discharged from the hospital. Well, we're in Bathurst, and it's available in Bathurst, Orange, Dubbo,
Awesome.
all around those areas.
I think you're getting at it's multifaceted. The reason why that health professional group has not been referenced by the women, like it's multifaceted, like probably just 6 reasons just there, but I guess it is that.
The education component from the midwives in the hospitals at the moment is not at the same level, and I'm talking about time as what it was, say, when I went through or something.
Oh yeah.
There's a very big education component when I went through that it's not there now.
Absolutely, and we are very much expecting that women will be much more autonomous and in Victoria, you might be discharged on day 4, day 5, and the maternal and child health nurses have till day 14 to pick you up. So there is a potentially big gap. So, what we find is women do feel very isolated and alone in the community, terrified a lot of the time, and that having a phone line they can call is really helpful for them. So we are reassured ourselves at the ABA that what we are doing with the helpline is genuinely helping to keep women breastfeeding longer than they would have done otherwise. And for the most part, we would like to do more. We have some millennial mothers are a different cohort of mothers, so they're having their babies younger than the Gen X. And they are approaching motherhood quite differently. We're still in the process of learning what that's all about, but certainly the women who are having their babies at 28 years old at the moment in Australia are a very different cohort to the women who've come before. And we are not sure that a telephone line is going to serve their needs. So we are looking more and more at live chat and live messaging services, and we find at the moment we're staffing that for 4 hours of an evening, and we're finding that take-up of that is actually quite good. And what we're finding is that people, they want to come on, they want to ask their question, and they want to go away again. And they want to do that at the time that suits them, and they're saying things like, well, I can message, and then nobody knows I'm talking to anyone, they don't know who's overhearing the phone call, and that they want to message because it doesn't wake the baby up, all sorts of different reasons. But so it's changing our model of how we need to provide that peer support. We have groups where women can go, sit with the counsellor, meet with other mothers, but there are access problems with that. So particularly from women from different ethnic minorities, people who live in rural and remote areas might not necessarily get to that group. And for some women, it's a real barrier, the idea that they're going somewhere to meet complete strangers and hang out with breastfeeding women when they don't feel they're very good at breastfeeding. That can prevent them from coming to groups in the first place. So yeah, this is our live chat. We're doing from 8 till 10 at the moment. We're trying to expand that. We're looking at expanding that, and we're any week now we're launching an app. We're very excited about it. I just plopped this in just in terms of primary healthcare, and where do you all who work in primary healthcare get your information about breastfeeding? So we've got the Australian Breastfeeding Association, we've got our website, we have health professional seminars, which I can highly recommend as being awesome. We had Natalie Shanker come and talk to us this year from the UK, and we run those all over Australia. But literally this week, this new website has launched it's essentially from Medela. So Medela do an awful lot of research and put an awful lot of funding into lactation research. And there are ethical problems with that, but they try and keep things as separate as possible. And what they've done is they've made this rather lovely website called Lactamap, which is designed for GPs. So this is a care pathway and education website, and GPs, practice nurses, can sign up to it, and when they have a woman with a particular problem, they can have a look at it. And I think I can tell you what, if we run short and I've got things to talk about, I'll take you through the website because it's interesting. But we'll carry on at the moment because I think I've got enough to talk about otherwise. But I just wanted to flag that up, particularly in a primary healthcare setting, because this is really useful and they're building on it. It's got really lovely little videos, it's got lovely kind of positioning and attachment. Everything I'm going to tell you, they're going to tell you as well. And because they're aiming this specifically at GPs, the reason they're aiming this at GPs is because we know that GPs' knowledge of breastfeeding is especially low. They get almost no education on breastfeeding, and unless they have a particular interest themselves in it, it's not that easy for them to access that education either. So when, about 10 years ago, there was a survey done of GPs in Australia as to where they got their breastfeeding knowledge from, and the commonest place for GPs to get their breastfeeding knowledge from was either having breastfed themselves or from having their partner breastfeed. It was not an education-based kind of knowledge. We're hopefully working on that, and it's part of the National Breastfeeding Strategy that we're going to talk about a little about as well, to increase that education of GPs, because that is often where women will go when they start to have initial problems. But hopefully this will help. So I'm going to keep coming back to Western Australia as being a key example. This comes from the Hartman Research Group over in Western Australia. They have a lot of money going into research in Perth at the moment. Millions and millions of dollars are going into breastfeeding research over in that research group. They mainly look at components of breast milk. They're mainly the scientists looking at what breast milk does. They have a little bit of mechanics of breastfeeding research going on over there as well, but they are feeding that back really beautifully into the community around Perth. In Western Australia, they have a population that's quite discreet, easy to access, and so their education has been very successful from King Eddie. They've got really beautiful policies. It's just all working really nicely, and we're seeing that in the breastfeeding rates. When they're measuring breastfeeding rates over in Western Australia, it's looking at the moment as if they've got 75% exclusive breastfeeding rate at 4 months. We're all a bit, hang on a minute, because that's fast. That's a very fast increase from where we've been. Nothing has moved in a very long time, but this is a very sudden increase. Some of it's going to be to do with the fact that millennials are different people. They are thinking about the world differently, they're accessing different information, and they're behaving differently. As I keep saying, they're all vegan. Of course they breastfeed. But it's very interesting that we are actually making some progress. It's also very interesting that lactation consultants are going, I don't believe that. But I think it's true. And this is all part of that.
Can I ask, with this Lactamap, has ADA contacted all of the health pathways to ensure that this is in the health pathways for every PHN or every LHD or HHS?
I literally got this 3 days ago.
Sure.
So I've had a very quick look at it, and it's good.
Yeah.
But yeah, and we generally take our evidence at ABA from the same pool that they do.
So I'm just thinking, like, what I will do when I go back to my PHN is I will be calling my health pathways people and saying, look, you got to upload this site to health pathways.
Yeah.
I think it's Amanda's
I think it looks pretty damn good. It's very much, it's all the same language, and I didn't see anything that didn't make me very happy. And I think it's amusing they're using the same colours. I'm sure that's intentional. This is what I wanted to talk to you as well. Where's the mouse? Here's the trackpad. Okay, so we'll just have a quick look. So this is King Eddie again. So what they've got at King Eddie is they've put their BFHI education online, which is awesome. So for doctors, allied staff, they've got these modules, 2-hour modules, 1-hour modules, that entirely free. You can sign up to them, go have a look at them, they're awesome. They're BFHI accredited, they're free, they're online. For midwives, for student midwives, for lactation consultants, they've just thrown it out there to the world, which is really fantastic. This has made us all very happy. And another beautiful thing that King Eddie have done, their breastfeeding resources. So they've got this lovely, this particular one, I'm kind of jumping ahead of myself because I'm going to talk about this a lot later, but this is exactly what we want people to know about the first feed, breastfeeding, how breastfeeding works, the fact that babies can do it themselves, and just having a look at that and comparing that to what we're going to talk about in a little while, this is exactly what we want. And King Eddie are already there, which is really nice. I'll come back to that later. You'll see why. I'm so happy about that. Okay, so in terms of primary healthcare, one of the key issues that we have with breastfeeding in the community is bad advice. The number one reason why women stop breastfeeding is bad advice. Bad advice about the way their baby is behaving, bad advice about feed frequency, bad advice about medications, bad advice about alcohol. Basically, most women stopped breastfeeding before they wanted to. We're not about making women breastfeed who don't want to breastfeed. We're about helping women to reach their own breastfeeding goals. Most women want to breastfeed. 98% of women in Australia initiate, and most women started out wanting to breastfeed for longer than they end up doing so. One of the key reasons are things like bad advice about medications. The vast majority of medications are safe for breastfeeding women. However, we are incredibly cautious about babies and medication. And we have a very laissez-faire attitude towards formula. So a lot of people still think that formula is completely safe, and there are no risks, and that it is definitely going to be better than giving breast milk with a small amount of medication in it. However, what we know is that for the vast majority of medications, very little gets into the breast milk to begin with. Babies are not particularly good at absorbing breast milk and the constituents of it themselves. And the vast majority of medications, when we actually look at what happens, you cannot measure in the baby any of the medication. This doesn't get through to them. If you think about it, you take an oral medication, it's got to go through your gut, it's got to go through your liver, it's got to get processed, then it's got to get into the milk. Breasts are contained in a fatty layer, which is very similar to the blood-brain barrier. Really, really similar. So if you think about it, any drug that gets through the blood-brain barrier can get into breast milk. So little molecules, alcohol, caffeine, those kind of little things. But big molecules like ibuprofen, they just can't get into breast milk. It really is pretty much impossible. Very, very low levels of large molecules can get into breast milk. The breasts are designed to protect babies from toxins in the environment. So they're really very good at that. And babies, the medication then, only a very small amount has got into milk, and then the baby has to absorb it. It has to go through their gut, through their stomach, through their, hepatic portal system, and then finally get into the baby, and very, very little gets in there. And their guts aren't particularly good at absorbing anything at that stage. A lot of it's, that's why baby poo is inoffensive, because essentially they're pooing out milk. So So our caution around medications and babies is for the most part really, really unnecessary. But we have very good evidence, and so ToxNet, LactMed, is the resource that GPs and practice nurses should be using. And what this is a database of medications. So if we have a look at, for example, at sertraline, what this database tells us is what this molecule does, and we know what it is. We know how it works, we know what the levels are. They talk you through the studies. The problem with this kind of research is that what they tend to do is we can't do double-blind studies on women. Here, you take this medication and breastfeed, and you don't, because this is very unethical. So what they do is they have to go recruit anyone who has decided to keep taking their medication and is still breastfeeding, and then they measure the drug concentration levels in the mother, in the baby, and in the milk. But they're very small numbers. They're 16 women here, 8 women there. It's whatever they can get their hands on. So that's why the evidence looks the way it does. And then they come to conclusions about, there's a lot of this, the effects on the breastfed infants, no adverse effects have been seen, and eventually there's a lot of this evidence will get down to the effects of what it actually does to the process of making milk. Does it affect that? And then they give you all the references. So, and this is public information, and I am very much in favour of giving this to women and saying, this is your drug, this is what you're taking, you make an informed decision about whether you want to take this or not.
Is that just for lactation, or does that do pregnancy as well?
That is mainly for lactation. If you want that, so every state has their pharmacy helpline. So in Victoria we have 2, I don't know why, but every other state has 1 phone line, which is based in a hospital, which has the pharmacist that you call if you want to know whether drugs are safe for pregnancy and lactation. And they have the experts. So Rodney White is the one that everyone always talks about. He's our pharmacist in Monash in Melbourne. Very nice man, always answers the phone. I don't know how he gets any work done. And if women have any concerns about their medications, they can call up Rodney and he will tell them exactly where things are. The thing you need to know about pharmaceuticals and women is almost no drugs are ever tested on women. Because we are troublesome and get pregnant and have all these cyclical hormones, when they test drugs, they test them on men, and they've always tested drugs on men, not women. So we have no data on women to begin with, and women and men have very different physiologies and react to drugs very, very differently. So to begin with, there is a bias in medications. And every medication will say in the little insert, do not take if you're breastfeeding, because they have to say that, because they've never tested it on breastfeeding women. So whether it's, even if it's a drug that literally cannot get in to breast milk, because any drug that you have to give subcutaneously, because you can't give it orally, gentamicin, all those sorts of things, you can't give them orally because they get denatured by stomach acid and all that sort of thing. Of course it can't get into the baby. Of course it can't, because the baby has to eat it too. But they will still say do not give him breastfeeding. Battles that we have to fight. But we have good evidence about this. And for the most part, even if there is a medication that a woman is not advised to take if she is breastfeeding, there will be another medication, there will be another alternative. Most of the time. Another question that you're going to get an awful lot about is alcohol. There is a lot of misinformation around breastfeeding and alcohol. And we have a very lovely page on the Australian Breastfeeding Association website about this. We also have a leaflet, and we have an app. We have an entire app devoted to alcohol and breastfeeding. It's called FeedSafe. And FeedSafe, you put in your weight and your height and how much alcohol you've drunk, and it will set a timer off, and it will tell you when your milk is out of alcohol. However, tell me, what's your legal limit for driving and alcohol in South Australia for blood alcohol level?
Is anyone from South Australia?
Is it same as everywhere else? I think it is the same. So what is it? 0.05. So 0.05. So if your blood alcohol level is 0.05, your milk alcohol level is 0.05. It's nothing. It's really nothing. 0.05 is nothing. It's very, very, very little alcohol in that milk. Apple juice contains naturally about the same amount of alcohol as 0.05. There's a little bit of fermentation that goes on in apple juice. But people worry about it. If you are very, very drunk, there might be a little bit more than that. It might get to the point where there is some theoretical risk to the baby. But you'd have to be really, really drunk, and you'd have to be really, really drunk a lot of the time. And the message that we give to women around this, if you're drinking, don't give them your breast milk because your breast milk's contaminated, give them formula instead, is actually quite a dangerous message. Because nobody who is drunk should be looking after a baby. It doesn't matter if they're formula feeding, it doesn't matter if they're breastfeeding, it doesn't matter. If you are under the influence, you should not be caring for a baby, because people who are drunk and caring for babies make unsafe sleeping choices. So we know that the SIDS risk, the risk of dying, well, it's a SUDI risk, the risk of sudden and unexpected death in infancy goes up on weekends, and the peak is New Year. So every other childhood accident goes up during the week when people are busy and running around and working and not paying attention. But SUDI goes up on the weekends, and it goes up Christmas, New Year. Peak is New Year's Eve. And that is because people are drinking, people are taking drugs, people are putting babies in ad hoc sleeping conditions. People are saying, oh, it's only one night, he can sleep in his bassinet, he can sleep in the car seat. That's when people get into trouble, when they're drunk and they're not making safe decisions. So the message we need to give to people is that nobody who is drinking needs to be looking after a baby, and that it's not the milk. The milk is not a problem. It is people falling asleep with babies because they are drunk on sofas in unsafe sleeping situations. And it's people putting babies in car seats to sleep and saying, oh, that's a bit tight, and undoing the straps and then falling asleep, and the baby waking up, getting upset, turning over. And we had a baby that turned itself over in the car seat, went up over the top of the car seat, and then strangled itself on the top of the car seat. They strangled themselves in the straps of car seats. And that's what happens. It's got nothing to do with the milk at all. So the message around this are all wrong. And it doesn't matter if people are breastfeeding or formula feeding. Breastfeeding is generally protective against SUDI, and we know that women who exclusively breastfeed reduce their chance of SUDI by around about 90%. And that's for lots of different reasons. It's because breastfed babies wake up more frequently. And we also know from studies what they did on babies who were breastfed and babies who are formula fed, that babies who are breastfed actually have different sleep patterns. Their ECGs are different from formula fed babies. Formula fed babies sleep more deeply and don't rouse as easily. So if they're getting themselves in trouble, if their airway's getting a bit blocked, if they're stuffed under blankets, they're not as able to rouse and wake themselves up as babies who are breastfed, who are just a bit more lively. And this is one of the reasons why people do formula feed, because babies sleep better. And we sedate babies to sleep with, 150 mils of formula will make them sleep for 8 hours, but it's not healthy. It's not safe for them. That was one talk. How am I doing for time? Okay, awesome. This is Naomi Hull's little presentation. So I'm just going to talk to you about world breastfeeding trends. I'm going to whiz through this fairly quickly. And Naomi gave me her presentation because it says some interesting things about Australia generally, but it's only a quick one. So World Breastfeeding Trends Initiative is a tool which tracks 10 indicators of policy and programs to support women to be successful in breastfeeding. And it's a way of benchmarking each country, how well are they supporting women and babies. And we have these reassessments every 3 to 5 years. The Australian one was just done, and Naomi, who's one of my colleagues, was the person who spearheaded this. So this provides information to the government about the gaps in policy and where we need to provide extra support, systems, policies to make sure that breastfeeding is protected. 97 countries around the world have completed it, and 35 have repeated the process. And it was time for us to do one in Australia. Yes, we think about breastfeeding as being a choice. It can't be a choice until it's a right. You can't choose something until you have the right to achieve it. And at the moment, women are sabotaged by lots of different things, and their ability and capacity to breastfeed is sabotaged. They don't have the right to breastfeed yet, and they certainly don't have the choice a lot of the time. The choice is taken away from them. And there are arguments that children have a right to be breastfed for their long-term ability to achieve their potential. Okay. So these are the people who are part of this. So there are some powerhouses in here. Naomi Hull, she's amazing. Julie Smith. Julie Smith is from Canberra. She is a powerhouse. She's just awesome. You got.
The one who did the economics.
Yeah, she's an economics specialist, so she's the one that tells you how much the economic power of breastfeeding. Mary Peterson. You got Dale, Susan Tabia, who I used to be, who used to do my job. Carleen Gribble, she's the breastfeeding and emergencies people. So there's lots of very exciting people, all getting together to advocate for breastfeeding and for babies and for women. And we know that this process has had some really good outcomes, and that in countries where they've raised up their score, it is helping to support women to breastfeed. There are 15 different indicators to work out how good your score is for your country. So do we have a national policy? At the time, we did not have a national breastfeeding policy. We do have one now, and we're just about to have it renewed again. I'm going to have an enduring policy. So we've improved in this way, which is nice, but at that point, we did not have a national policy. BFHI accreditation required across all maternity services nationwide. We have some, but not all. It's expensive. Getting BFHI accreditation for your maternity hospital is expensive. It costs thousands of dollars, and it also costs in training of staff and in processes and the kind of education that you need to give women, and to some degree, some of the support that you need to give to women. So it's not a free thing, although it's good for breastfeeding. The WHO code. So the marketing of breast milk and breast milk substitutes, how well is that controlled? How well is that monitored? And Australia doesn't do particularly well in that. And if anyone's come through the airport lately, you'll have seen those adverts for toddler formula, which are going up everywhere. We've got a lot of new formula manufacturers in Australia. Way out in Gippsland, all these nice little companies. You've got the adverts, the people are down there, those A2 people. There are lots of little companies who are not towing the line in terms of milk marketing in the way that the bigger, older companies do. So we've got particularly marketing to China, really unethical marketing going on to China at the moment. Maternity protection. What are we doing for parental leave? We've got workplace accreditation for breastfeeding friendly. We're getting better, but we still only scored a 6 out of 10 because there are still some huge gaps in terms of particularly supporting women. If you have a premature baby, your maternity pay doesn't get extended, and we have some women who have to go back to work before their baby has even been discharged from hospital, which is really, really sad. Health professional education, we did especially badly on this, so particularly in terms of nursing curriculums, GPs, how much education are the people who women expect to know about breastfeeding, how well are they doing? Really not terribly well in Australia. Community sport. So we have the Australian Breastfeeding Association. It's a voluntary basis. How much is the government doing in terms of supporting women? How much kind of funding is put into that? Not enough. What kind of information, national information programs, health promotion goes on towards breastfeeding? Very, very little. And it's extremely contentious. When we're talking about breastfeeding, it's difficult because there's always somebody in the corner saying, but not everyone can do it. Don't make them feel guilty. We have a real issue with this as an individual counselling of an individual woman with an individual set of circumstances, and breastfeeding as health promotion. And dividing the two, we don't see it in the same way as you don't have hear anyone saying, don't promote exercise because this person is in a wheelchair. We don't have that same argument for some reason, but in breastfeeding we do. And one of my arguments that Americans really hate, whenever I go talk to Americans about this, they hate this analogy. But I always say that breastfeeding is a bit like losing your virginity. Learning to breastfeed, it's two people doing something they've never done before, which is normal bodily function, but things can go wrong. You can get little infections, you can get sore bits. It cannot be appearing to work very well. It cannot be as pleasant as you thought it was going to be. But we don't ever say to women, oh, you're just not good at sex. No, just don't do it. Just have IVF instead. You know, we don't, because women have a right to have a sex life, but we don't think that women have a right to have breastfeeding work for them. It's something, you can just give formula instead, don't worry about that. The whole attitude to it is just a bit crazy. Why don't we think that this is a right? So yeah, our information around it is very, very manipulated by formula manufacturers and that message. Formula manufacturers spend $5 billion a year on marketing alone. Okay? If you think about that, $5 billion on marketing alone worldwide. And we can't compete against that. And a lot of the messages around formula marketing are sneaky. I was picking up, so I've got a whole load of stuff in my bag from downstairs. Breastfeeding is perfect. Breast milk is the perfect way to feed your baby. Oh, who can do perfect? Formula's all right. If it's, I can't do perfect. Breastfeeding is best. Well, you don't necessarily need the best. The formula manufacturers are very happy for us to say that breast is perfect and is best. What they don't want us to say is that breastfeeding is normal, that breastfeeding is a right, that breastfeeding is something that should not be sabotaged. So we have very few babies born in Australia these days with HIV. There are a few, and at the moment in Australia our message is that those babies should not be breastfed, though we always know that there are, at Pazan's there was a paper about the fact that women do their own research on this and come to their own conclusions, and that women who are fully covered by medication and whose CD counts are as close to undetectable as possible are probably fairly safe to breastfeed as long as they're exclusively breastfeeding. As soon as exclusive breastfeeding stops, the gut lining becomes just a little bit damaged by any other food, and then the chances of acquiring HIV increase for those babies. So as long as babies are exclusively breastfed, globally the message is moving towards the fact that breastfeeding in certain circumstances is probably going to be recommended if formula feeding is in a circumstance is going to be unsafe. But even in a Western developed context, there are some women who are advocating for themselves that they would rather breastfeed. Breastfeeding during emergencies. Policies and programs in place to ensure that mothers, infants and young children will be provided adequate protection and support for appropriate feeding during emergencies. We really don't have this one covered, and we have a lot of emergencies in Australia. We like to think of ourselves as being developed, but we have bushfires, we have massive floods through the middle of Brisbane city centre, and those are situations where infant feeding can really be jeopardised, and we need to have better systems in place for managing that. And monitoring and evaluation. We did very badly in terms of actually the data we're collecting. We don't know what women are doing. We don't know what they're feeding their babies. We're not collecting that data a lot of the time, certainly not consistently. And so our ranking, unfortunately, third from the bottom. Below the USA. And the UK, who has the lowest breastfeeding rates in the world. So we're just, but this has given us motivation that we really need to get on and make things better for women. And the fact that Australian women do so well at breastfeeding, and actually globally they do pretty well. We breastfeed, we initiate very well, we keep breastfeeding in comparison to some other places, relatively well. It's all off their own backs. It's not on the support that they're getting in that country from anywhere else, and it's on from the support of other women. It's from things like the ABA. So the World Breastfeeding Trends are continuing their advocacy work, and that's where a lot of the drives for policy is coming from. So I'm going to talk a little bit about the Australian National Breastfeeding Strategy. So our new strategy is, yes, here we go. The council meeting on the 8th of March. It's been ratified and discussed, and it will be publicly available on the website in April. It wasn't there yesterday, I checked. So any day now, we're going to have a new one. I think I've seen it. The last one I saw, I think the one that it's going to be. And we've been working hard on fighting to have the right kind of legislation and support in there to make our policies and our guidelines and our strategies ones that are going to be evidence-based and effective. And hopefully, we're all excited to see it, when it comes through, it will talk about things like the 10% of babies who end up in special care. Those are babies that have a priority for breastfeeding, not because they're premature, though yes, because they're premature, but why they were born premature in the first place. So most babies who are born premature have a number of associated risk factors. It's not just sort of accidental. It's poverty, it's family violence, it's a range of different disadvantages that those families have, which mean that they end up in the special care to begin with. And so it's just like an example of where the most high-risk babies are, and where those are the babies that need the most support to breastfeed, because they're those babies for which breastfeeding can do the most amount of help, not just in terms of the nutrition of that baby and reducing risks of things like necrotizing enterocolitis, which can kill premature babies, but also in terms of mother-child relations and how we feed babies and how we learn to interact with our babies and what we think about our babies and feel about our babies. I'll talk about a little bit about that in a little while. But also, overall, giving an attention to the mother and the child, which isn't just about the medical care of that baby, about the emotional care of that mother and that baby. And we know that improves mother's mental health, babies' long-term mental health. So hopefully this strategy, when we see it any day now, will give us some ways forward in how we need to move forward in supporting women and babies. So I just wanted to talk around family foods and some of the evidence about that, because this particular presentation, which was written by my colleague Susan Talia, talks through some of the evidence which in primary care you may get questions around, because mothers of babies in this sort of 2, 3, 4, 5 months, when they're coming in for their immunisations at 2 months, 6 months, they're going to be canvassing you for all sorts of opinions on all sorts of things. And if you're a nurse, they expect you to know stuff. So, and there is, again, a huge amount of pressure from infant feeding companies to try and get people to give as much processed food as early as possible. And they've come at it in all sorts of sneaky ways. So they market foods as being suitable from 4 months, when nobody should be giving any baby any food at 4 months. And they sort of talk about, we tried really hard to convince us that it was going to save us all from allergies. I'll talk you through that. So we had a summit on infant feeding over in Melbourne in 2016 to look at the evidence for health outcomes for infants and whether exclusive breastfeeding for 6 months is a really good idea in high and middle income countries. The best infant evidence on breastfeeding is global evidence, and we have really good global evidence. But when we talk about exclusive breastfeeding, what we mean is that the baby has nothing except breast milk. Oral rehydration salts, vitamins, minerals, medicines, but nothing else, not even water. And infants should be exclusively breastfed for 6 months of life to achieve optimal growth, development and health. And it does not matter about the context. All babies. So we had this summit. The question was, when should family foods be introduced into the infant's diet? So, and the key recommendations have not changed. I think since about 1986. People keep saying, oh, they've changed. They haven't. Not since about 1986. When your infant is ready, at around 6 months, but not before 4 months. Introduce a variety of solid foods, starting with iron-rich foods, whilst continuing breastfeeding. All children should be given allergenic foods, including peanut butter, cooked egg, dairy, wheat products in the first year of life, and this includes infants at high risk of allergy. And there's no evidence that hydrolyzed formulas are recommended for the prevention of allergic disease, although they are marketed as such. So these recommendations have not changed. Continuing breastfeeding for 12 months, according to one guideline, and according to WHO, for 2 years or so. Basically keep going until the child themselves wants to stop breastfeeding. Well, mother and child, between the two of them, they negotiate this. Okay. There was some contention about whether early introduction of potentially allergic foods might reduce the risk of allergies. But when we look at the evidence, and we have a whole range of different levels of evidence and randomized control trials, so LEAP, EAT and STAR have all looked at the timing of high allergy foods. The introduction of peanuts to high-risk infants before they turned 1 significantly decreased the incidence of peanut allergy in at-risk children. So our old advice used to be, when I had my babies, it was like, don't eat peanuts when you're pregnant, don't touch a peanut, don't go anywhere near a peanut. But now we know that actually introduction of peanuts is much safer. But these infants were between 4 and 11 months when they were first introduced to peanuts. And the window of opportunity is somewhere around 4 to 11 months. It's not the earlier the better. There's no need to introduce peanuts before the age of 6 months. EAT study looked at the introduction of allergic foods at 3 months and 1 and 3 years. The difference was not particularly statistically significant. And STAR looked at the introduction of egg at 4 months, whether it reduced the risk of infants with eczema having egg allergy at 12 months. No significant difference in allergy to egg was found between the groups exposed from egg from 4 months to a control group. Early introduction of allergic family foods before 6 months does not reduce the risk of food allergy. So the guideline is still the same. When your infant is ready at around 6 months, but not before 4 months, start to introduce a variety of solid foods, starting with iron-rich foods, whilst continuing breastfeeding. The whilst continuing breastfeeding is what we think is probably the important message. And that's one of the things that we keep saying to people, is that whilst you are introducing your highly allergic foods, keep breastfeeding. Because there are all sorts of little constituents and ways that the mother's immune system is talking to the baby's immune system through the medium of breast milk that help to modulate that risk of sensitization. We're not really sure how it all works, but we're fairly certain that keeping breastfeeding through the introduction of those foods is probably what's important, not necessarily when you introduce them. So our WHO guidelines and our NHMSC guidelines are fairly similar, and even the Centre for Food and Allergy Research are all supporting this around 6 months, but not before 4 months. Doesn't make any difference. 6 months of exclusive breastfeeding did not decrease or increase the risk of allergy and asthma. Again, Japanese study, Exclusive breastfeeding for 6 to 7 months neither increased nor decreased the risk of asthma. We know that children who are breastfed for longer periods have lower infectious morbidity and mortality, fewer dental malocclusions, higher intelligence than those who are breastfed for shorter periods. And that IQ data, very, very tricky because of the way that different people breastfeed to people who don't breastfeed. But we think it is, again, the longer you breastfeed, the improvement of in terms of IQ. But it is more a case of the earlier and the longer formula is given instead of breast milk, the lower things go.
That's a good question about that.
Yes.
Is maybe the variable of it the human interaction with the mother, like the eye contact, etc., that kind of thing, rather than any...
There is really no way of knowing, except there was one study that was done on premature babies way back in about 1989 where they actually did randomized control babies, and they had donor milk versus formula for a group of premature babies, and they RCT'd it, and they found a 9-point IQ difference. And that's the only time they've ever done it, and it was unethical, and they'll never do it again. But the one time they actually RCT'd breast milk versus formula, it was in premature babies who are a very different population from term babies. But what they found was there was just in terms of the milk they were getting in a bottle between the two made a difference. And it makes sense. There are 200 different oligosaccharides in human milk. They've only just put one into formula, and they got really excited about it and started marketing it as being, has oligosaccharides? It has one. And there's all sorts of things in human milk that we don't even know what it's doing in there. If you look at human milk, the thing about the oligosaccharides, which I find really fascinating, is when a woman makes milk, the most amount of calories that she puts into making that milk, the most energy that she puts into actually making the milk, goes into these oligosaccharides, more than 200 of them. And the baby doesn't use the oligosaccharides at all. The gut bacteria eat the oligosaccharides. So the majority of the nutritional energy that's actually gone into making that milk isn't about feeding the baby at all. It's about feeding the bacteria that live in the baby, which is just amazing. There's a lot of fats and calories and stuff and lactose that the baby does absorb, but actually in terms of how much energy it takes to make human milk, that making those oligosaccharides is a real big investment of that mother in making those little molecules. And they're all about feeding the gut bacteria. Fascinating. Yes, we can. SIDS risk, I've already told you about SIDS risks. And that there's a lot of guidelines around SIDS. Still the commonest cause of death in children under the age of 1 past the first 6 weeks. We still have a problem with it, and it will always likely be a problem, but we can reduce it much further than it is at the moment by having sensible harm minimization guidelines. So we know that breastfeeding, well, that's okay. Formula feeding increases the risk of mortality, diarrhea, admission to hospital, lower respiratory infections, admission to hospital, ear infections, dental malocclusions, and formula feeding decreases IQ. So, what about health outcomes associated with exclusive breastfeeding to 6 months in high to middle income? Even in high to middle income countries, we can measure those differences between exclusively breastfed and formula fed babies. Where people will tell you it doesn't matter because we live in Australia, it doesn't make any difference here, it's only those babies in Africa. No, even in our population we can measure the differences between babies, particularly in terms of respiratory infections, gastrointestinal infections, and there's increasing evidence around diabetes, leukemia, all those immune functions. So we know that particularly in the first 3 months of life, the immune system is learning self from not self, and it does that mainly through what's going through the gut. And breast milk helps the baby to learn self from not self. So we have good evidence that if all babies were exclusively breastfed, the rate of childhood leukemia would decrease by about 20%. Things like certain neuroblastomas would halve. Diabetes would be reduced significantly. We know that in China at the moment, rates of type 1 diabetes are increasing dramatically in small children. So since 1997, rates have been increasing by about 17% a year in Shanghai because of the introduction, we think, of infant formula. It's not been in that population before. Women haven't been drinking cow's milk, and babies haven't been given cow's milk formula because they just didn't have that in China, particularly because lactose intolerant, they didn't have a lot of dairy consumption in that area. We suspect what it is it's the insulin from cows in the cow's milk, which is sensitizing the mothers and the babies, and then going on in children who are predisposed to develop type 1 diabetes, it's sensitizing them in infancy, which then going on to develop type 1 diabetes. We don't see it in our population because we've been giving babies all sorts for so long. We've been giving babies bits of cow's milk and porridge and all sorts of things since, the year dot. But in a population where this has not really happened before and it's quite novel, we're seeing that correlation. How am I doing for time? Half an hour, okay.
So what happens to the population who can't breastfeed or have very difficult or traumatic experiences with that? What's then your next option, best option?
In an ideal world, donor milk. And we're getting better. The government, notice the Labour government has suggested that if they win the election, they're going to put $14 million into supporting breastfeeding, and half of that is going to be going to ensuring that premature babies have access to donor milk, every neonatal unit in the country. In an ideal world, why we can manufacture human milk. We can do it. It is technically possible. They actually got almost to the point of genetically engineering a cow to make human milk. It's just not economically viable. There isn't a demand for it. There is no demand to improve formula in our society because everyone's told that formula is good enough. Everyone is told that it's perfectly fine and it's good for babies, and don't make women feel guilty about the fact they can't breastfeed. Don't tell them that formula is bad. So it means that there's no drive to improve formula. There's no drive to make it safer. There's no drive to improve how it is for babies. And that's one of the reasons that we want to criticize it, is so that they have a drive to improve it. The cost is going up, but the quality is not changing since the 1970s, really.
So for the population in rural or remote areas that can't access
milk.
What is there a better formula than others?
Formula is generally formula.
Yeah.
They are all standard, and any standard formula. There are some that are certainly less recommended. Soy formulas, lactose-free formula that has glucose instead of lactose, when lactase insufficiency in babies is a metabolic condition that will kill you in the first 3 days of life and simply doesn't exist. But we're still marketing a formula for babies that supposedly have this condition that you can buy off the shelf. It's ridiculous. So we don't know if some of the ways that breastfed babies are things like mental health and IQ, we don't know if that's method of feeding or what they're being fed. So there are ways of feeding babies with a bottle that are probably better for babies than others. So we talk about responsive feeding, about feeding to need, about small amounts of feeding, and that's when we start talking about normal breastfed baby behaviours. Babies wake frequently. Babies are going to be feeding every 2 hours. Probably most babies are going to be feeding 10, 12 times a day. Whereas the messages that people who are formula feeding get, give your baby a big bottle of formula and they're going to sleep for 6 or 8 hours, and that is not healthy, and this is not a good message.
So it's to make it more like the natural breastfeeding rather than giving them the bulk.
Yes. And that babies need interaction to feed, swapping them from side to side. There's lots of things that we don't know what it is that's making the difference. Not prop feeding. Prop feeding is a disaster. It is a disaster in so many different ways because it stops. Babies get a cuddle with their feed. If you're prop feeding them, the first time I walked into childcare and saw my 4-month-old in a bouncy seat holding their own bottle, and there's a whole little row of them, I was so horrified because it never even occurred to me. I'm a neonatal nurse. We feed our babies. That in a daycare centre, they would think it was great that babies could feed themselves. They don't even get a cuddle with their feed. There's a lot of the quality of interaction with babies,
Have we seen on expressing? There's a lot of women going back to
Oh,
work early.
we're starting to get that data, and
expressing and
Oh, yeah.
breathing and that routine.
We are certainly seeing that there is a difference in outcomes between babies who are breastfed and babies who are breast milk fed. And there's also we think that when babies breastfeed, they are communicating with the breast. When they create that vacuum, something from the baby's mouth is being sucked into the breast, and the breast is having a chat to it and tailoring the breast milk just that little bit more carefully towards that baby's needs. And we don't know how that's happening, but we're fairly certain it is. So we know that the microbiome between babies who are breastfed and babies who are breast milk fed is a little bit different because of that. And it's so complex and we don't know what's going on.
And it's a much smaller group, that group of babies.
Oh, that's a whole can of worms. You got a baby with a cleft palate and you live in Thailand, your baby will be breastfed and successfully.
Well, I
Yeah.
with the cleft lid, but
Yes.
I was very dedicated. And
It takes work, it takes support. We have an issue. This is being recorded. I should be careful what I'm saying. But yeah, no, that is a real issue.
Statistics about
It is possible. It is very, very possible to breastfeed babies with cleft lip and palates. It doesn't happen because the support is not there.
I mean, I just found the week where I had to express while he was having his surgery just about did me in.
Oh yeah, it is so hard work.
The whole time expressing and feeding.
There are so many women in Australia who are triple feeding. So many. Anyway, we'll skip through this because I don't have much longer, and there's a very important. Okay, in ways we're feeding babies, purees are a very bad idea. Babies do not need to have purees. It predisposes towards feeding problems and health problems. The research on this is snowballing. Purees, they're more difficult to manage. They impede the development of oral motor skills. And it reduces the opportunity of infants to learn to recognise foods by their appearance and their ability to trust of what they're doing. Deprives infants of the opportunity to experience different textures, reduces opportunities for parents to model eating choices they wish their offsprings to make. If you're eating a salad and the baby is eating mush. Overuse of purees, implications for health. Food that can be swallowed quickly contributes to excessive weight gain. There's no evidence to support spoon feeding. We don't think that spoon feeding is a good idea at all. And this is a fairly radical change that happened about 10 years ago when Jill Rapley over in the UK started talking about baby-led weaning. Infants over 6 months are capable of feeding themselves without need for cutlery. They will reach out, steal food off your plate and start to eat it themselves. I know, my 5-month-old did it with a strawberry. There was no way I was getting that strawberry back off her. She was going to eat it. Spoon feeding allows the caretaker to assume control of the infant's intake with consequent risk for overfeeding. It's the same with bottle feeding. Bottle feeding overrides infants' ability to regulate how much food they want to eat at that time. If most bottles, if you hold a bottle upside down, generally the fluid falls out of it. If you put it in a baby's mouth, they have to swallow or drown. It is very easy to overfeed with a bottle. It is very easy to overfeed with a spoon. And it is about that responsiveness that's really important. Spoon feeding mitigates against shared meal times. There you go. Got 5% of babies breastfeeding, still being breastfed at 12 months. I think that's going to go up. I think it's going to, when we get new data, I think it's going to be a lot higher than that. But we're still getting quite a lot of babies down there at 2 and 3 months being given food. And exclusive breastfeeding rates, we're nowhere near. There's a lot of babies being given a lot of other things right in the middle of there. And these babies' sensitizations to allergies and all sorts of things. ABA members did much better, you'd expect they would. Okay. I'm just going to whiz through. Oh, this is me. This is my favourite picture of breastfeeding, and I show it every time I have to talk about breastfeeding. I show this picture, because I love it. This is what I want breastfeeding to look like. Not this. Not this. This sprawly, natural gorilla breastfeeding. And this is what mothers and babies do. You see how these babies, they're kind of vaguely in a nice straight line. The chin is in, the nose is out, both cheeks are touching the breast symmetrically. I mean, this little chap could have his hand up a bit. But you can see how this mother is not having to support this baby's weight particularly. She could take that hand off. She could have a cup of tea, it'd be great. this mother could probably take both her hands off, lean back a bit more. This is what we want breastfeeding to look like. Way back in the 1950s, Niles Newton, I love her research. She was the one that gave herself electric shocks to see if it would affect her letdown reflex. She found, I'm missing a slide, damn it. Anyway, she found that 80% of women had nipple pain, and then she said we should give them alcohol. We don't do that anymore. But what we do know is that as many as half of well-term infants leave hospitals not fully breastfeeding. So the majority of babies are not kind of successfully, happily breastfeeding. A lot of them are being topped up with expressed milk, they're having cup feeding, they're having all sorts of things, and a lot of babies are being given very large volumes in bottles. For mothers, what happens in early motherhood is not what they expected, it's not what they were warned about. Engorgement, nickel damage, anxiety of a milk supply. They thought they were going to be good at this, and they're not, and they don't know why. I'm going to tell you why. Women feel practically unprepared for parenthood. A lot of them have never seen a baby being held or fed before. They're petrified, terrified of taking their babies home. What we found in my particular piece of research is that women said they were really grateful if they had a cesarean because it meant they could stay in hospital longer. That's awful that women feel that way. What we found in our research is that 80% of first-time mothers experienced significant nipple pain, 60% had nipple damage. Really, 60% had nipple damage. We were there, we were measuring it, we were looking at it in these 400 well-educated, fairly middle-class women who'd been to a breastfeeding education class. They were your gold standard women in a lot of ways. That's just kind of what they meant. What we found was, see that kind of blue there is women with no pain. 80% of them got to no pain, but it took them till 8 weeks to get there. You know, it really hurt for a long time, and so there's still some women in significant pain at 8 weeks down the track. There's lots of different reasons for breast and nipple pain. It can be really complex, but most of the time it's actually very simple. However, it really affects women. It really affects how they interact with their babies, how they think about themselves, their experience of early motherhood. Now, I've got a 10-year-old. There's a woman that has a child in my daughter's class at school, and we were getting on well. We were having play dates. It was fine. And then one day she asked me what I did for a living. And when I told her I was a lactation consultant, she couldn't make eye contact with me anymore. And she just still can't. Her experience of breastfeeding was so traumatic that she doesn't even want to be my friend because I'm a lactation consultant. That's how important this is to women. And we talk about just give formula. No.
I remember when my daughter's 21 now, but I would sit in the industry of breastfeeding, and I had women who did not know I was a midwife who would apologise to me because they'd been unable to breastfeed their babies, and I was just, I wasn't, and they were feeling so bad. Yeah. And it's just tragic.
It really is, and this is why I'm a lactation consultant. It's not because I think, breast is best. It's because I want women to be able to breastfeed because they want to breastfeed, and they expect their bodies to work. And it makes me really annoyed. I used to work at the Women's in Melbourne. Our breastfeeding information, I worked there for 3 years and I never managed to change it, is still wrong. And it is wrong in the way I'm going to tell you the most important thing I can tell you today, and that is when we teach women to breastfeed, we still say the same thing. Hold your breast in one hand, hold your baby in the other, wait for your baby to make a big mouth, bring one towards the other. When we do that, we slam their chin on their chest. We do that to them. We go like that. And we've been teaching women this for years, and that is what the problem is. That's all it is. We need to stop doing that. When you think about how you swallow, we're all nurses. I have to teach this to NICU nurses, and it drives me mad. We are all nurses, and we know that when we drink like this. Babies are just exactly the same. When they drink like this. And what we do in most breastfeeding positions, really don't get me started on that one. We put the baby's chin on their chest. And so what the baby does is it goes, and the mother goes, why are they pushing off? They don't want to breastfeed, they don't want me. And they feel cat-handed, and they can't do this thing that they have to look for this latch and this special K thing, and they have to tip this here, and they have to do this. And their first experience of breastfeeding their baby is, I'm incompetent, I can't do it, my baby doesn't want it, everybody's screaming and it hurts. So of course they don't breastfeed. They have to be really determined to breastfeed through that. That first experience of breastfeeding is, I can't do this. However, if you put a baby upright between a mother's breasts, and you just leave them there, they do what we remember way back, we saw that King Eddie, that kind of bob, 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 bob. What they do is they bob, 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 bob. They follow their cheek, and they use their hands. And if they've got sore nipples already, no woman wants you to let their baby do this, but they use their hand to grab the nipple, they find the nipple, they squish the nipple, they make the nipple into the shape they want it with their little hands, and then they bob, bob, and they latch on like that, with their chin first, and their cheeks against the breast, and they use their whole bodies, and they use their whole bodies, and they do it themselves. And mothers go, oh wow, my baby can do that. My baby can find the breast. Isn't that amazing? And they don't have to do it. And their relationship with their baby has completely changed, because it's not about them having a fight. It's not breast boxing. It's not, it's them just lying there going, I just lie here and my baby's going to breastfeed itself. I've got the best, brilliant baby in the world. And for the majority of women, I'm a lactation consultant and I sit there in clinic and I get these women whose babies have never breastfed and they're 14 days old and they've been expressing every 2 hours and the world is falling apart and they've never latched and nothing's out. And literally all I do is put the baby there and tell them to leave it alone. And I get so frustrated with how easy it is to fix that problem. Sometimes it's a little bit harder. Sometimes what you want them to do, if it's really all not growing well, straddle the baby over their thigh and tell the mother to hold the baby around the rib cage and lean forward and line up their nipple with the baby's nose. And don't worry about the baby's head's fine. Just holding around the rib cage is literally to stop them touching the baby in any other way, because they've been so about babies and they've been told to do all this stuff. Hold it around, and the baby, generally speaking at this point, gets a look in its eyes like, finally, I know what I'm doing. And then they latch. And then you can just lean them back a bit, and then everything's all right. It's a dirty trick, and I don't like to use it. But it just gets everything in that position, and all it is about that. I had a baby in the neonatal unit, got, 16% dehydrated. It was, nobody could figure out what was wrong with this baby, and they were all going, we're going to have to bottle feed this baby because nothing's working. There's loads of milk, but it just won't put on any weight, and it won't feed properly. And I walked in, and they had it in a football hold, and the baby was going suck, 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 swallow, suck, 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 swallow, because it couldn't swallow because its chin was on its chest. And and they would say, it keeps pulling off, we don't know why it keeps pulling off. And I'm like, well, because it wants to swallow. Because it's going suck, 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 swallow, suck, 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 swallow. And it's something about how we think they're specially able to feed on. No mammal feeds lying on its back apart from dolphins. I googled this. You can have videos of them. Dolphins actually feed upside down, following underneath their mum. Think about it, puppies face down, kittens face down, horses like that, underneath their mums. Mammals don't feed upside down, and we get babies feeding, and they do it because they have to feed because they want to survive, but they're not happy about it, and it's not a nice experience, and it's just somehow we just got it all wrong when we medicalised it all, and we started doing this, and bottle feeding's out here to get the breast out of the way, and we try and breastfeed baby, and it's actually the solution to it is, look at this as an experience of your first breastfeed. Just look at that. That's not what she's expecting when she's just, and this is a mission. Is it any wonder that women don't want to do that and find it undignified and painful and no thank you when we're doing that too? This is one of our common, bless Rebecca Glover, she worked really hard to try and improve things, and she thought about it scientifically, and she made this handout, and I was given this when my baby was born, and we're still giving it out now. But you've just had a baby and your brain's all foggy, and that is what you get? It's not up to you to feed your baby. Babies feed themselves. They just, poof, on they go. Babies, it's their developmental goal to feed themselves. Cave woman, 16-year-old cave woman, She's lying there, she's to the baby. That baby crawls up and feeds itself because otherwise, no written handouts for that, cave woman. Cave baby is what we have to think about. What did cave baby do? And they just got on with it.
Can I ask a question?
Mm-hmm.
So I'm a midwife, and we all know those babies that get on and suck like there's something on a dummy and rip the crap out of the nipple, and does that come back, like when you let the baby go by itself, does that come back to that first feed and then having that really good first feed with the really big blood open up? Like how do you prevent that every time?
You can restart it. You can restart it with going back to basics at any point. Yeah, you can go at any point. Yeah. But that kind of upright koala hold, that will fix a lot of things if you got to that point. Particularly if you've got a lot of nipple damage and the woman is really reluctant to even have that baby anywhere near them. Once that's the one I use to get them on, because sometimes the baby led when they're doing it, it's just a little bit too much if there's a lot of nipple damage, and just go into a kind of clean AMP straight on, and they will go, oh, actually that doesn't hurt, because it shouldn't hurt if they're positioned correctly. It shouldn't do. And that's just King Eddie again, because their resources are so beautiful. Just a little slide about motherhood and generally this idea that as women, you get to being 28, 30, you've had a routine, you've had control, you've had a life. Suddenly having a baby demanding of you and your body leaking and being undignified. And we get told as women that our bodies should never leak. And it's leaking everywhere. No one tells you that your breasts are going to leak. And all this stuff, it's just a lot. And that's why women need a lot of peer support at that point. They need a village. They need people around them who've done this before. And often what they've got is an accountant. Their support system is, a tradie who can go to the pharmacy and buy a tin of formula that has instructions on it. So we have lost our support and our peer support, and the Australian Breastfeeding Association is doing our very best to try and bridge that gap, but we need more. This is lovely data that's just come through, which is making us all very happy. So this is exclusive breastfeeding at 4 months of age. So you've got Canberra, you've got Western Australia. A lot of people are saying we don't believe this data because it looks so good. I'm saying actually, maybe it is, maybe actually we're doing some good, and there are 75% of 4-month-olds exclusively breastfeeding, maybe. It would be lovely. I think we've got a different generation, and I think they're doing it for themselves because they're certainly not doing it,
Can I share a story about that?
Mm-hmm.
I was recently had an older lady in for a dressing with her daughter there, and the daughter was crocheting something, and I said, "What's that?" She said, "It's a boob beanie." What? She said one of her daughter's friends is pregnant and wants a boob beanie, so when the baby's on the breast, the baby's got the boob, and she's just showing the world that this is what I'm meant to do. Yeah. And I hadn't heard it before, and I just thought that was just, and I think it's that different mindset with the millennials.
I really think it is. If you look at everything from menstrual cups.
Oh.
I mean, this is a whole different relationship with our bodies. And it's a feminist attitude to how our bodies should work and what we feel about it and what we're going to say about it. And I think that's where it's coming from. I think and they've got good information now, and we've got they want to do it. However, globally, when we look at this is formula marketing and formula growth, and the thing is, this is standard formula, this is follow-on formula, and this is toddler formula. And they invented toddler formula way back here in 2000 or so in order to get around the milk marketing recommendations that they're not allowed to market this, so they invented this so they had something to market. This is literally an invented product that nobody needs, and all the recommendations say, no, you don't need it. 15-month-old babies do not need infant formula, or do not need toddler formula. And yeah, look at that. They're now selling way more of it than anything else. And a lot of that is actually breastfeeding mothers, because they feel so bad about the fact that their breastfeeding hasn't worked out for them that they feel they need to give their baby just something a little bit more special, a little bit better. So they love the idea, these guys, that breast is best, because they know that those women who think that breast is best are the ones who are going to keep on giving their baby formula and buying it. And environmental impact of that on not just the tins and the sterilisation and the bottles, but the land that is cleared to graze the cows, to have the milk, it's just outrageous. Just in terms of in the primary healthcare setting, again, bringing it back to primary healthcare, we do need to supplement babies. Things go very wrong for lots of different reasons. We do need to supplement them, but our primary goal is always both to feed the baby and to try and optimise and solve those problems of maternal milk supply. Milk hasn't been removed properly initially. That production of milk has been interrupted because the baby hasn't been feeding effectively, and we have to rescue it, and we have to do it very effectively and very quickly whilst feeding the baby. Things that we can do to keep babies breastfeeding even when supplies are not going well. We don't have to give them bottles. Little supply lines becoming much more popular. Ways of keeping babies breastfeeding, particularly when milk isn't flowing very well and baby's just a bit not convinced that actually this is how you get fed at all. They're like, this doesn't work for me. Getting a little bit of flow going at the breast can really help to convince the baby that breastfeeding is actually going to get them fed, and also convince the mother that their baby can breastfeed. So, fiddly, time consuming. That baby's chin is probably on its chest a bit too much. But it is something that you might see coming through a little bit more. You can buy them in pharmacies, these supplementary lines. And sometimes when supplies aren't there, and when babies, they might have, women who have had a breast removed, women who have insufficient glandular tissue, those women who really, really want to breastfeed their babies but simply do not have enough milk, they are still breastfeeding their babies and having that relationship with their baby. So when you're asked about what can we do, actually this is what we can do. Not everyone wants to do it. It's not going to work for everybody, but for some people, this is actually really important. And it still gets that little bit of milk supply, and it probably can cut out all that ridiculous large amounts of expressing and triple feeding that goes on, because the baby is still feeding. And we talk a lot about breastfeed, and then when the baby gets hungry, then give them a top up. Actually, you don't want babies to think that breasts aren't things that get them fed. So at the moment, we're starting to think maybe the message might be, give your baby a top up and then breastfeed them for dessert, so that they fall asleep kind of satisfied and happy at the breast, rather than thinking the breast is the thing that's going to make them hungry and frustrated. It's all about where you think that milk supply is and what you think the problem is, and how, that can get a bit complex. But the ways, we're changing all the time how we think about things. There's a lot of expressing going on in Australia at the moment, particularly with women who aren't going back to work, but there's just a lot of interference between breast and baby and what's going on. So things are changing. Just a nice picture. Nancy Moorbacker, she's got some lovely some videos on YouTube of ways that we want women to see these kind of positions with breastfeeding. People don't see this. There aren't pictures of breastfeeding anywhere. Most maternity hospitals, you won't see a picture of a breastfeeding baby anywhere, and if you do, it's a picture of the back of a baby's head. Not very helpful. Whereas these kind of things, so you chin in, nose free, both cheeks touching the breast, baby in a nice straight line. Everybody relaxed. These are the kind of things we want. How are we doing for time? Okay, I'll just show you the video that I would have shown you.
Breastfeeding attachment for health workers. Mothers have breastfed their babies throughout time without paying much attention to how the baby was attached to the breast. Babies may not be attached well and doesn't let the baby feed as well. Instead, align the baby's nose to the nipple. Be patient. Wait for the baby to open his mouth very wide, like a yawn.
Our baby's crying.
Then bring him quickly onto the breast, leading with his chin.
It's a very exaggerated.
A gentle push from behind the shoulders as the baby takes the breast can deepen the attachment. The baby is drinking well, and breastfeeding is comfortable for the mother.
There is a very nice one just
Most
there.
easily fits into the angle of the baby's mouth, can help the baby attach well.
This This is very mother-led breastfeeding, however. It's just some kind of nicer positioning.
Mothers are often worried their baby cannot breathe while feeding. Reassure her that babies' noses are designed for breathing when their nose is in the breast. Also, show her how to pull her baby closer to move his nose away from the breast. How do we tell if...
Just a small point there that you don't need to keep taking babies off and on and off and on and off and on. That makes nipples sore. Or that off and on, you can readjust them while they're on. Pull them across a little bit. Generally speaking, most of the time, if it's not quite working, it's pinching. The baby's nose is stuck in the breast. They want to come this way a little bit, and they want a little bit pressure behind the shoulders, top that bottom up, just to get the chin in, tuck the bottom in to get the chin in. And there's little readjustments that we can do. Now, this is global health media. Global health media, I'll show you quickly, because it's amazing. Let me out. Okay. Oh, there you go. That's all my favourite breastfeeding picture ever, Australian one. There we are. I will just because. So this is a no. Okay, it's .org. That's what it is. They are a Bill and Melinda Gates funded non-profit education, and they have the most amazing videos. They filmed them all in a developing world context, I guess because they're cheap, but and show a range of different. But the videos are amazing, and they come in a range of really exciting languages, which is fabulous. It used to be like one or two, but now they've got all sorts of things, and they've all sorts of kind of different things about nutrition and small babies. If you have anything to do with educating nurses or doctors, if you want to see really, really, really sick babies, the kind of babies that we don't see babies as sick as some of the babies in this, because they filmed them in a developing world context, well away from hospitals, and they've got babies with some of it's really distressing stuff. They've got babies fitting, they've got babies with, frank meningitis, and they're just, it's heartbreaking stuff, but it's really, really good education for nurses and doctors who won't get to see that kind of level of sick babies. And this is also, their breastfeeding videos are brilliant. They are, although they're filmed in a developing world context, they have world experts who have contributed to what the content is and the wording. That woman with her amazing voice, I could listen to it 10 times a day, and I often do. But they've got lots of lovely things. So for mums, for if you've got a screen that plays in your waiting room, you play the videos. They're open access, and they have got really lovely content, and it's all free. So I think this is one of my top tips for anybody working in this field, is that there are beautiful resources. There's lots of bad advice, but we've got beautiful resources coming through now, which are going to be really helpful, and we think it's working. We think it's generally a hopeful kind of message that things are, in Australia, improving, and we hope fairly rapidly. But we just want those messages, and there's just those little things about this is how we do. Just tell all your friends. We want those messages to get spread around.
And also, I know I often tell them, how often do you have a glass of water? Yeah, but that's the baby's fluid. A baby will drink. Yeah, so it's
those little messages about behaviour, and that we want babies to be waking frequently, feeding frequently, and that it's good for mothers and babies' health. I didn't talk to you about diabetes. Damn it! Though I need one sentence on it. Okay. If you have gestational diabetes, your chance of developing type 2 diabetes within 5 years is about 50%. If you breastfeed for 3 months, that chance of developing type 2 diabetes becomes very, very low for about the next 10 years. So you get 10 years of additional protection from type 2 diabetes from 3 months of breastfeeding. It resets the metabolism. So, and in terms of your risk of hypertension, heart disease, high blood pressure, stroke, ovarian cancer, breast cancer, they all decrease the longer a woman breastfeeds for and the more babies she breastfeeds. So if you never have babies or you don't breastfeed the babies that you have, your risk is intrinsically higher than women who breastfeed. And the longer, more exclusively women they breastfeed for. So pregnancy mucks up your metabolism. We get gestational diabetes because your metabolism starts to free up a lot more glucose for that baby's growth. And that metabolism needs to be reset, and the mechanism that women have to do that is lactation. And lactation positively improves women's long-term health by resetting their metabolism, particularly in terms of glucose metabolism and blood pressure, lipid profile. So all those things become, at the moment that message isn't getting through. It's not getting through to women, it's not getting through to health professionals, that actually some of our best evidence for why breastfeeding is a good thing is about women's health and reducing their risk of breast cancer, ovarian cancer, high blood pressure, diabetes. So I should have had a whole talk on that. But there's a lot to say about it. Any more questions? Thank you so much for listening through that very long